So we start with optical calculation blunders in IOL calculation. And it will be presented by Dr. Reshma. She's from Narayan Netralaya. I hand over the mic to her.
Good morning, everyone. So let us talk about optical calculation blunders in IOL power calculations. So we have different optical media starting from the tear film, the cornea, the lens, the vitreous, and the retina. And each of these media can induce some amount of aberrations and can result into some amount of prediction errors with respect to your IOL power calculations. So we'll go one by one and discuss one case scenario for each of these. So to begin with, you can see two case examples over here. One is one with a good tear film with no staining or with a regular ocular surface, and below that you see another bad tear film wherein you also see a poor repeatability of the keratometry readings and a distorted image which is formed. So a 56-year-old gentleman presented to us with diminution of vision for a period of 3 to 4 months, and he had grade 2 nuclear sclerosis and punctate epithelial erosions all over the cornea. The dry eye workup was also abnormal, with Shermer's being less than 10 at about 5 minutes, and so was the T-butt. Now, when we did his biometry for the IOL power calculation, as you can see, it showed an astigmatism of 4.59 at 156. Now, if we would have gone ahead based on this and planned a toric IOL for this patient, we would have probably implanted a model of T9, which would have resulted into an overcorrection of his astigmatism. So this is using the same biometry readings wherein we get a T9 on the Alcon toric calculator because we planned an IQ for this, no financial interest here. But what we decided to do was we went ahead and treated his ocular surface first. So after treating the ocular surface, we repeated his scans after a month, and we found that his astigmatism showed 1.84. Now that is a significant change from what it showed previously when we didn't treat the ocular surface. And of course there was a change in the toric IOL model as well. It showed a T9, and that resulted into a better visual outcome. Now, keratoconus, other ectatic corneas, post-keratoplasty, irregular corneas, all these are extremely difficult IOL power calculations. And in these cases, in these treated eyes or in these ectatic corneas, what happens is that there is a change in the relationship between the anterior and the posterior corneal curvature. So this is a case example of a 55-year-old gentleman who presented to us with diminution of vision for a period of 2 to 3 months. He had undergone hyperopic LASIK 2 years back, and he had grade 2 nuclear sclerosis with a posterior subcapsular cataract. So how do we plan a IOL for this patient? So as we are all aware, we use the post-refractive ASCRS calculator, and the calculator essentially needs you to enter the atlas readings. But in case you do not have this device at your disposal, the calculator ideally does not allow you to use any other. So any other machine is not. You cannot use you cannot use readings from any other machine interchangeably in the calculator. So where it says atlas, you need to enter atlas. But what if you do not have an atlas at your clinic? So in our practice, we have seen that EKR works equally well because that gives you a cumulative anterior as well as the posterior corneal curvature, and it adjusts it and then gives you a value which is similar to that of your simulated keratometry reading. So you remain in sync with your IOL power calculation because those are the calculators are modeled for a simulated keratometry reading. But the EKR, since it also includes the posterior cornea, it gives you a better result, particularly in these treated eyes or in ectatic corneas. So what we do is we see the flat, steep and the mean K reading across all the 4 zones, and we see the variation. So here we see the histogram and we see how broad-based the histogram is. Now suppose you want to plan a multifocal for this patient or an extended depth of focus for this patient, then apart from looking at the aberrations, we also suggest that you look at the EKR and you also see how much is the variability of the keratometry over the zones. So ideally, we go ahead with a ASCRS calculation, and we also use the Barrett True-K calculator. Now, the Barrett True-K calculator is basically for treated eyes or for ectatic eyes. It lets you choose whether it's a hyperopic LASIK, a myopic LASIK, or a keratoconic eye. So the ASCRS calculator uses a large number of formulae, and it also gives you an average IOL power, the minimum as well as the maximum IOL power. This was another case example of a 40-year-old lady who was diagnosed elsewhere with an advanced keratoconus and presented with a cataract. She had a history of using scleral lenses for both the eyes. So as you can expect, there would be some amount of contact lens warpage in these cases. So if you see, this was the first time she presented to us, and since topography is mandatory, you can see the broad-based histogram showing a large amount of variability. So would you really plan a toric IOL for this patient, even if she needs one? So we decided to discontinue the scleral lenses for her in her case, and we repeated the scans after a period of 3 weeks. Now, there are a lot of papers in literature who have suggested the use of high-power custom toric intraocular lenses for correcting high corneal astigmatism in keratoplasty and keratoconic patients with cataract, and they have said that they do well. Now, of course, all these groups have used different kinds of keratometry readings. So some have based their calculation based on the SIMK, some have used the TCRP. In our practice, in our institute, we rely more upon the EKR readings. So we discontinued the scleral lenses for her and we repeated the scans. The variability in the EKR was slightly better as compared to the previous, but now as you can see, I'll just quickly summarize. So as you can see, the EKR readings are almost 62 to 65. Now your normal calculator is not going to let you use a 65 keratometry reading. There's only one calculator which will probably allow you to do that, and that is the Kane calculator. Now the Kane formula was introduced in the year 2017. It's a relatively new formula, and it lets you use the keratometry readings up to 65. So we went ahead, planned a toric for this patient, and she had a good outcome as well. Now, when we come to the retina and the vitreous, there are changes in the estimation of the effective lens position, pupil size, and the role of angle alpha, and variability in the vault height of the IOL. Now, coming to now there are different formulae which use either the anterior chamber depth and the effective lens position to calculate your IOL predictions. Now, I'll just skip this part because we are all well aware of this. The visual axis, the optical axis, and the angle between the two is the angle alpha. This was a case example of a 70-year-old gentleman who presented 1 month later after cataract surgery, having a best corrected visual acuity of 6/6, but he was unhappy. So he had a large angle alpha when we did the eye trace. And so if at all it is a normal angle alpha and the IOL is centered, when the IOL is aligned with the visual axis, the quality of vision is going to be better as compared to that when it is misaligned. So this was another patient who was unhappy 1 month after cataract surgery, showing blurring of vision but being 6/6. So she showed a significant IOL decentration on the eye trace. If you can see, the angle alpha was almost 0.7. So similarly, there was a distorted point spread function on the eye trace and a poor contrast sensitivity. So that could have been the reason why she was unhappy. So this is just a summary of the same. Coming to the vitreous, a silicon-filled eye behaves differently as compared to that of your normal eye. And similarly, phaco-vitrectomy in case of gas tamponade. So we have had multiple literature studies wherein biometry in a silicon oil-filled eye has been seen. And similarly, if at all the patient has undergone an SOR removal, you need to calculate it differently. So this was a 25-year-old lady who presented with a diminution of vision for a period of 3 to 4 months. She was operated for retinal detachment, and it was a silicon-filled eye. So this was her biometry before, in the phakic mode, before the retinal detachment surgery, and as you can see, the axial length showed 33.96. Now when we repeated the biometry in the SO-fill mode, the axial length showed 28. So that shows you that you would have to rely upon the SO-fill mode when you're calculating, and that's a very common mistake which each of us may do. Thank you for your kind attention.
Thank you, Dr. Reshma. Any questions for Dr. Reshma? So I would like to ask you, when will you plan a toric IOL in KC, and when will you not go ahead with it?
Okay. So the most important thing is, if at all, toric IOLs in keratoconus are, especially in advanced keratoconus, function primarily to debulk the astigmatism. We are never attempting to completely correct the astigmatism, particularly if it's a high astigmatism. But yes, you can debulk. It also depends upon if at all the patient has been a chronic scleral contact lens user and has been happy with it, then you can probably debulk the astigmatism to some extent, and for the rest of the remaining residual astigmatism, he can continue using the scleral contact lenses. So apart from all these factors, the patient-related factors, we look at the topography, we look at the aberration. So topography, as I said, we look at the variability of the EKR readings over 4.5 millimeter zone, or rather the mesopic pupil size, which is the most important. In these cases, the mesopic pupil size was 4.5, so we took the EKR readings in the 4.5 millimeter zone. So if it's an extremely irregular cornea showing, then we would probably, it's better that you don't go ahead with the toric.
Thank you.